ourselves as a little bit more than just a healthcare IT company. We like to think of ourselves as really partnering and thinking about what the future is in the healthcare and the economy, and really thinking about it from a health and care perspective, not just healthcare IT and where you might have traditionally thought about us. The other thing is we've got a couple of hallmarks of how we go about working and developing and thinking about the future, and they really are around innovation and partnerships, and that's really what we're trying to showcase here with this panel. So a couple of our future directions and where we're focused. So first off, we are big believers in there's a next generation of the EMR. So the EMR tends to be what people think about as the transaction-based system within the hospitals and clinics and other healthcare organizations for how you care for patients and as a byproduct deliver care and have outcomes. We're really thinking about there's a next generation of an EMR and are partnered with Intermountain Healthcare on that. So we've got Mark Probst here from Intermountain Healthcare. And they went live recently with iCentra, which is leveraging Cerner technology, Millennium technology as the foundation. But as thinking about the next generation of EMR, we're thinking about how do we really take the care process models that Intermountain has developed and what they're known for around quality and bring them to life within the EMR to make it much easier and more intuitive to deliver care and the right care to the right patients at the right time, whether it be a physician, a caregiver, or another part of the healthcare team. The other thing that we're thinking about as far as the EMR is that it is not just about it being a transaction-based system, that really you need to think about it as a platform. And as you get to the integrated electronic medical records, it can't be everything to everybody. So we recognize also that you need to have specialty-specific applications that are able to leverage that platform and be delivered within the care and the workflow. So we're partnered with Geisinger. We've got Dr. Alistair Erskine here from Geisinger, who is can talk about our partnership that we announced yesterday, where we're taking some of the Geisinger-developed applications and embedding them within our electronic medical record so that they're available within that point of care. So the other thing that we are thinking about also a lot is population health. And our partner in population health, at least from the outset for a number of years, has been Advocate, and we've got Dr. Rishi Sika here from Advocate. He is based here in Chicago. They have been doing a fair amount within the greater Chicago area around managing populations. And very similar in the 90s when you think about electronic medical records and they were coming and they were beginning to kind of take form, there was a lot of best of breed solutions out there. So you had your emergency department or your surgery department, anesthesia, critical care, OB, all had their own individual solutions. At Cerner, we really envisioned a future where it was a fully integrated electronic medical record. So hence we're in 2015, and really that's all you're seeing is fully integrated electronic medical records. We think the same thing about population health. So when population health started becoming a popular theme, you had a lot of companies popping up who did analytics, who did care management, who were insurer-based solutions, who did things that were very specific to a small niche in that area. We believe that the future is a very integrated population health platform, and that is what we're working on with Advocate. And finally, interoperability. We are very much proponents of ensuring that data is available wherever it be needed for the care of patients and whatever they're doing. So with that, we've got Jitin Asnani. Good. I've been practicing that one, who is the director of Commonwealth. And he'll talk a little bit about Commonwealth, but Commonwealth is the group that has come together and formed this. We're a founding member of, with a number of vendors, other suppliers who have come together and formed Commonwealth. The goal is to create patient identity, national patient identity, availability, the availability of healthcare data for those patients to be able to take wherever they need in a very secure way. So with that, that just kind of gives a broad overview and setting up the panel that we've got. I'm going to turn it over to Dr. John Glasser. John joined us with the recent acquisition of Siemens Health Services. So he's a member of the Cerner team, and we're very pleased to have him. I think probably many of you know him because he's well known throughout the industry. So, John?
Thank you, Joanne. I'd like to add my welcome to Joanne's, to all of you for being here, and my thank you to the panel, although you haven't said anything yet, but thank you for being here. I'm sure you can say very insightful things. Just a little bit of elaboration on the Siemens acquisition, which you all know occurred or was consummated on February 2nd. And it brought in a huge number of associates. 97% of the Cerner or Siemens staff accepted the Cerner offer, and obviously brought in a large number of clients. So far, that transition is going remarkably well. So the staff are being absorbed and beginning to work with their Cerner colleagues. But we also, in the last couple of weeks, announced, or will announce, I guess we are announcing, the fact that 3 key Siemens customers have committed to moving to Millennium. So this is Charleston Area Medical Center. This is the folks up in University of South Alabama Health System, but also Commonwealth Health up in the sort of 3 hospitals in the Pennsylvania area. So we're beginning to see a big traction of people who are embracing the technologies and the services that the Cerner folks have to offer. So anyway, off to a very good start. So delighted to see that occur. It is a great pleasure, and I'm going to turn this over quite quickly to our colleagues here because this is the reason you are here. As Joanne mentioned, there is a remarkable series of shifts that are occurring in the nature of the technology that we use to support the delivery of care. And in fact, if I teach a course at Wharton, and if you were all MBA students, we talk about the notion of dominant design of IT platforms. It's when the industry goes through amazing shifts, and you've seen this in transportation, manufacturing, financial services, et cetera. The design and the approach, the core systems that are used go through a big transformation. And that's what we're in the middle of now. So the systems of yore will look different in the years to come because of the shifts that are occurring in the industry as a whole. And these are shifts, as you all know, that are related to payment changes and emphasis on managing populations and keeping people healthy and providing a continuum of care and coordinating care across that continuum. So we're pleased to have these gentlemen here who represent various aspects of that shift and various aspects of the industry to talk about some of the challenges that they face. So I'm going to do a brief, tell you who they are. I believe we have bios and more background information available to you, so I won't go through that necessarily. But to my immediate left, longstanding friend and good colleague, Mark Probst, who is the Chief Information Officer and Vice President at Intermountain Healthcare. To his immediate left is Dr. Alistair Erskine, who is the Chief Clinical Informatics Officer. I think you see these all behind you from Geisinger Health System. And to his left is Dr. Rishi Sikka, who is the Vice President of Clinical Transformation at Advocate Healthcare. And then last but not least, Jit Naznani, who is the Executive Director of Commonwealth. So gentlemen, I want to thank you for being here. Now, I have a series of questions, and what I thought, I'll put it out there, and you know the drill. We'll start with you, Mark, and so unless you want to take one of your free passes and move it down to Jit right off the bat, and wait till that occurs or comes back at you. But anyway, and we'll start and then move to the left here. But as you contemplate the, sort of the range of challenges that are faced in this industry and the application of IT to addressing these challenges, what's the biggest challenge that you all face when it comes to connecting different health information sources? Mark?
Well, at the risk of being a one-trick pony, it's clearly the lack of standards, the lack of ability to ubiquitously move data from one system to the other and have it be computable and understandable between those systems. The technology to connect these things really isn't all that difficult, but the fact that each system uses data in a different way, has different standards for what that data might look like, it makes it very difficult to get the context and the actual meaning of that data in the disparate systems. So the lack of those standards is a true challenge.
Yeah. So we're making progress on the standards committee, the federal efforts, making progress on that?
The word is being used significantly more than once. So I think that's a really positive step. And I do think some of the things we're seeing between FHIR and what we're doing with the APIs, it is being helpful and headed in the right direction. It would still be easier if we could just get to a good set of standards.
Okay, fair enough. Also, what do you think?
So I think that, in looking at interoperability, obviously we move some information around. So it could be data points, information that is derived from that, or actually just decisions and assistance and other things. One of the problems is that we really need to interoperate on the entire continuum of care, not something that's just between acute facilities or between clinics. So the big problem with interoperability is, to begin, is access to the right data that you need. So I need claims data, I need non-healthcare data to be able to get a proper image and healthcare data to get a proper image of the patient, to be able to provide the right context as to what's going on. And then, of course, when you bring all that together, you have a semantic problem in terms of what people call. I send something called apple, it gets received as orange. That makes things increasingly difficult. So I think those are some of the big challenges with interoperability. I mean, at Geisinger, we have a health information exchange. It's sustainable, it's regional. We're moving that information around amongst post-acute care facilities and hospital facilities. But I received a 75-page CCD document on one particular patient, and I can tell you that in 10 minutes of a visit, it's going to be a little challenge to get through.
Yeah.
So the information is flowing, but it's not yet, I'm not yet able to consume it in a way that is practical.
Okay.
So I agree with these comments. I'll give a little bit of a different spin from our perspective as one of the largest ACOs in the country. And we're responsible for over 600,000 lives actually across all of our accountable care products. And one of the issues we have is knowing that a patient that we're seeing in one system or in one environment is actually the same patient that we're seeing when the data is coming from another system actually. And this notion of a single patient identifier, what we internally refer to as, at least as a master patient index, is really critical to being able to tap and leverage the data. And it's one that we've actually spent a great deal of effort and resources on. And it's kind of, to be honest with you, somewhat shameful actually that some of that effort is actually manual in some respects. So this notion of having a single patient identifier is one challenge that we've encountered and that we've worked on. The other flip side that I'll give is, going back to some of Joanne's comments earlier about sort of what is beyond the EMR and the post-EMR world. I think certainly from our perspective, because we seem to have every EMR you can imagine, it's not really the EMR that's really the key, it's actually the data that comes out of it. And I think one of the frustrating things is, we're doing a lot of great work in predictive models and analytics in partnership with Cerner, and we've got these really talented and brilliant, high-powered statisticians and data scientists that are part of the team. And you know what they spend a lot of their time on? Cleaning the data. What a gross misuse of their time, actually, is to just clean out the data because of this issue of standards that really aren't consistent across the different systems. Think about how much we could actually get in terms of productivity and advancing the knowledge of our industry and actually improving care better by just dealing with this issue of standards.
I think you got to find a Mark, and that's it. What I would add to that is, what's listening to what Mark and Alistair and Rishi have said, what's really, the thing that's really missing is a pragmatic path that allows a participant in healthcare to actually be able to share information in a way that they know that it's surfaced to the right person at the right time, that it's semantically interoperable, that it's usable. And that path is what is missing in my view. That there's been a proliferation of standards over time. None of them is that great. None of them actually hits the mark that we want. There's gradual work that we're seeing out in the industry, and I feel very good about where some of that is headed. Things like the CCDA, which was kind of a crude step, but it actually got us a little further. Things like FHIR, which Mark alluded to, which now allow you to pull out just that nugget of data that you were looking for, not the 75-page monster that we've had to deal with in the past. Those things are really good positive steps, but it still doesn't get you to the place where you actually know that if I'm looking for a patient, so I can get the information on that patient, know who that patient is, whether through an identifier and other means, and then go get those records and surface it to the clinician at the time that they need it. There's not, even if you check the boxes on all those other pieces around the standards, you still don't actually have a solution there that works without the real challenge that is faced from a technology point of view, which is you're still doing a number of point-to-point interfaces. You're doing a number of interfaces to the broader community, and you're never going to capture it all unless you unless there's a utility that really makes this healthcare information exchange ubiquitous across the care continuum to the points that we observed too.
Thank you, and I think that was the Standards Rescue Squad coming.
Yeah, I know. Somebody else was happy about that.
So I'm going to go off script here, which is probably we're within 10 minutes of this shocking. But I'm curious about and so if you go back in time, so golly, it was about 6 years ago that the standards committee was stood up, and the policy committee was stood up, and there's a lot of energy and effort that went into the standards process, et cetera. So okay, we've had 6 years, going after this kind of thing here. And if we had Karen DeSalvo in front of here and some of our senators and saying, all right, this is how you guys can help us, and I don't mean to put all this on the government and that this is full government, but they obviously have a huge role in this thing. And Mark, you're going to see Karen later today. And as we know, Congress is all over this interoperability thing, like what do we need to do to really advance it? So given the issues we've had, what would you tell them? I mean, what would you tell Karen? And if we had the Senate staffers here, what would you tell them about, here's how you guys can help? Here's what, we had 6 years, we learned a bunch, so now here's what phase 2 ought to look like. And Jim, why don't I start with you and we'll work our way back.
Sure, absolutely. So if I had that opportunity to chat with Karen, what I would tell her is that we've had 3 decades of standards development, starting from HL 7 1984 and coming forward. Over the last 6 years, the HIT Standards Committee has made tremendous progress. But we still live in a world of proliferated standards. And those are narrowing down, and the Standards Committee, other bodies are doing a great job at trying to narrow them down, trying to take it forward. What we only have just started is actual data sharing networks, which actually will that actually power the use of those standards for real information exchange across the care continuum. We are more or less in 1994, 95 for the internet, where we stand today in the health industry. So it's super important, it's critical at this stage to let the market have its chance at enabling real solutions. Even as the continued focus of the Standards Committee is to bring down parity, to bring down to a parsimonious set of useful standards, the time is actually now starting really for the proliferation of real solutions. That's where we are right now, and that's the mindset with which one should think about.
So I think I'd probably first confession I'm not as technologically savvy as the other panel members here. So I don't think I would comment directly on the what of the standards, but I would talk with her about the why. Why is this of critical importance? Why is this something that must be done? And if you really look at the environment in several perspectives, first off, you have health systems, providers, medical groups who are all interested in taking a greater degree of risk and bearing that risk financially with respect to the provision of care. And taking on that risk really requires you to have a full spectrum of information and understanding of the attributed patients you're responsible for. That is a reality that is playing out in the marketplace. You put that against the further backdrop of increasing consolidation, either that's through merger, acquisition, or through partnership with disruptive competitor, and you really see that this need is not a theoretical one. It's not an academic exercise so that people can get better information out of their system. It's not an exercise that is confined to just one stakeholder. This is actually holding back the further improvement and transformation that is needed in our industry, in our country, to really improve the quality of care at a lower cost point. I would focus on that why with her to really accelerate the need for this in that regard. Now, I'll leave it up to sort of smarter folks to determine what are the nuts and bolts, but the need is great, and that need really needs to be understood, and that why, because that would be the driver for accelerating this.
So a couple of things. First of all, I think there are some things in the standards that are getting in the way of liberating the innovative, harnessing the collective power of the people who are trying to solve this problem. So, there's cages of constraints in terms of how things are being applied. I'll give you an example. So if the data is coming from the electronic health record, and so the data provenance is from the electronic health record, and it moves over to another system, could be enterprise data warehouse, could be an app, could be something else like this, there's discussion about saying, well, those need to be meaningful use certified elements as well. So I think that's, you've got to find a nice balance between being able to constrain what we do and drive, some standardization, and also being able to allow it free enough to be able to innovate. But the other thing I'd say is, I would say I don't need another name for information exchange. because we've had community health information networks in the 90s. We've had regional health information organizations in the 2000s. We have health information exchanges now. It may be that if we keep changing the name, that's not going to solve the problem. Okay, so instead of just moving clinical documents around from place to place, maybe an alternative is to move data and its functionality and its workflow around from system to system, which is where we're talking about how some of these FHIR and Fs are a way to approach this, because what I discover at Geisinger in my system, if I want to take that, not just data, but in the workflow and the knowledge, and give it to another system that uses the same system as mine, or indeed give it to anybody else, I can't do that today, and I want to be able to make sure that the interoperability is a much more of a plug and play the whole workflow system rather than just the data points.
Well, I tell her what I have told her.
Okay, well, why don't you let us know what that is?
This is a national emergency to get these standards in place. I mean, tens, if not hundreds of thousands of people are certainly not living as well as they could, and many, many are dying because we haven't taken the time to solve this problem. That we have to send a 75-page report that isn't going to be digested, probably isn't going to be looked at, and does absolutely no good for anyone. So I think we have a national emergency here. I think it needs this level of attention. I believe it needs to be legislated, that we will have standards in place and it will be done in a certain period of time. When has Congress actually allocated any money or responsibility to get these standards done? And so we've talked about that. We've also testified to some of the congressional committees on this exact point. I'm really concerned about where they're going. If you look at some of the legislation that's out there, it's actually, again, probably changing the name more than it's actually dealing with the problem. We have plenty of standards. We got a boatload of standards. Why can't we pick the ones that are going to be the most useful, at least today in our understanding of what would solve these problems, and put them in place? We'll save lives, and we will save billions and billions of dollars. And we just need to make this a priority. It's probably a lot more important than maybe VDT is in right now, as a function for our EMRs.
Yeah, I mean, my own 2 cents, I would give ONC almost dictatorial power on calling the standards. Well, she'll make some misses, but enough to get rid of a lot of the fuzziness. Second, be more thoughtful about the process ramifications of certain things, so you don't get the 75 pages, that, and the other. And the third, and this was brought up by a couple of you, is to begin to imagine that we're going to evolve from data interoperability to process and intelligence interoperability. And so what does that look like? And Smart FHIR, an example of what it could look like, et cetera. But anyway, there's an evolution that will be occurring here. So we just talked a little about standards, and so that's not the only issue, or the exchange of it. I know it's way up there, so that's where we started with. That's where we started with. No, well, you can take it a little nap from here on out. But there are other challenges that, IT challenges that exist as you move from the fee-for-service volume emphasis to, what we all know is coming, which is the incentives for value and health and all that other stuff here. So when you look across the range of IT stuff that has got to occur, and also mindful of the series of conversations going on at HIMSS and innovative products that are all across the exhibit floor, what are some of the other big challenges that we are facing, and some thoughts about how we address those? So Alistair, I'm going to start with you, and then we'll move back to Dan.
I think one of the challenges is, if you're looking at population health and care management, I'm a practicing internist as a hospitalist, and the picture I have in my mind, for better or for worse, is that doing population health management when I'm taking care of a patient in the hospital in an acute care setting is almost like driving a car at 65 miles an hour down the road and trying to change my shoes. In other words, there's when I'm in the care process, I'm focused as a doctor on obviously that patient and that series of patients, and that's what I'm worried about. Now, my partners at the Geisinger Health Plan, which is half of our business is taking care of patients, and the half is the health plan. They're much more better minded at population health management. They're looking at cohorts of population, they're subsegmenting that population. So for integrated delivery networks like us, you have this role change. The folks that are used to doing population health management versus the folks that are actually delivering the care. And the IT challenge is to make sure that distribution of role and those views are being organized in a way that's consumable by both parties.
Yeah, I'll build on that a little bit and say that I think some of our current technology and infrastructure is problematic because it is physician-centric and it is patient-centric. And you might say, well, those aren't necessarily bad things. You know, the aspect about physician centricity is that really to deliver on the goals of population health, which is improved quality and improved quality at a lower cost point, it really is a team-based effort. And that team orientation really needs to be reflected in the software and the technology that's out there. The second aspect, I said patient centricity, and folks would be like, well, there's nothing wrong with patient centricity. Actually, the problem is when you're in population health is it's not about patients anymore. Patients implies a state of illness, right? In population health, the goal is wellness. Really, we need to not have solutions that are patient-centric, they need to be consumer-centric. And when you talk about consumer centricity, are our applications, is the technology and the infrastructure really there to engage consumers who may be well, who are gearing towards wellness, and who are driving in that regard? And that's where I think that there is a whole host of opportunity for us to actually get product and technology that is consumer-centric and really engages them, much as many of these apps that are on here truly engage them and really take this away from patient centricity to consumer centricity to get population health.
That spoke directly to my heart. The reality of healthcare today, and this, it's been said to death that it's really sickness care. And the way I start thinking about it is that to the degree that we treat patients as persons, that we are creating 3D views of a person, and that their data, whether coming from a healthcare setting, a traditional healthcare setting like a hospital or a clinic or an ambulatory setting, or pharmacy, or from a post-acute care setting, or from a Fitbit app, or other things which are now beyond those healthcare settings. Being able to create that 3D view of a person that's actually consumable and usable and actually accessible to the provider, to the patients, and to those who need it, beyond those two constituents, that's what is a paradigm shift for the industry that we're starting to see. The way we've architected Commonwealth is it's all about the person at the center, and all data flows to that person at the center. And although today it is providers who use that data, it is because they are the ones driving much of sickness care, population health, and so on today. Being able to create that picture and being an architect so that you can create that picture over time is a fundamental thing that's missing otherwise in the rest of the industry.
Yeah, and I mean, obviously these are really good comments, and I agree with all of them. As we've looked at it, we've really looked at where does accountability lie within healthcare. And there's a lot of parties involved, and so I agree with consumers and patients. But one of the things we really need to facilitate is how we keep the clinician, because that's the expert. These doctors, they're the experts. How do we keep them engaged in the process, even when they're not in the clinic or when they're not in the hospital? And how do we facilitate that? Because in many ways, with the traditional EMRs we've put in place, we've added a whole lot of additional work for them that historically they haven't done. One, we need to definitely streamline that, but then we need the connections when they're at the gym and they have a question or something is noticeable, and it very quickly brings the clinician into the process as part of solving the problems for our patients. So I think we have a lot to do with that in aligning those needs.
I'll give a story that I think highlights this from just a couple months ago. So, one of my twin girls, she's at the time she was 6 years old. She had a fever, she had a sore throat. I'm an emergency medicine physician, took a little flashlight, looked in the back of her throat, and I was absolutely convinced it was strep throat, right? I also kind of have a rule that I don't like to treat my own kids. So I'm there with my wife, who's not a physician. I'm talking, I'm pretty sure she's got strep throat. I think we got to bring her in to go see the pediatrician. And we're just talking about what that's going to take for us, right? So for us, and we're both working parents, one of us is going to have to take half a day off, is going to have to drive into the city. Actually, we can't park our car there. We have to park our car several blocks away. go up to the office, go up to like the 10th floor, register, be seen by a nurse. The nurse comes back, then the physician comes, takes the same history over again. Then they bring in a third person to actually do the strep swab, right? And basically 2-3 hours have gone by. And we're just saying, gosh, we don't have that kind of time. We don't have that kind of ability to take that time off and to go through that. There's got to be something better or another way for us to go, right? So what would some folks choose? Well, I guess you could go to the emergency room at any time, any hour, and get things taken care of there. But that's higher cost, and that's inefficient provision of care. That's totally counter to population health. It makes you see when you look at this that our entire infrastructure is not consumer-centric. It is not really geared towards an efficient interaction as we've expected probably of almost any other aspect of our consumer life. And when we talk about technology and infrastructure, where is that technology and infrastructure to help make that experience, which I'm describing, a truly consumer-centric experience for my daughter and honestly really for her two parents?
A couple of thoughts on comments, and we'll sort of again go off script here shortly. One of the things you're pointing out is we're taking models that we've had for a long time and fusing them. So we have the individual patient model and the population health model. Here's the care provider, here's the health plan, and we're fusing them. And we're fusing in the notion of team-based care. These are really different ideas. It's easy to say. You can be up here and say all this stuff, but boy, oh boy, the pragmatic reality of causing that to be is really hard. And so I think it'll be a collective industry challenge about how you all who are on the care provision side and us who are on the care supplier side come to grips with these models and we'll have to iterate. It's not like we have a perfect blueprint across the board on these things. But anyway, I want to get back to the consumer and the engaging of patients here, and I'll just sort of a personal struggle on my part to get my head around this type of stuff. On the one hand, you got a category of folks, I'm chronically ill. I have high cholesterol and I have sleep apnea, so I'm your basically chronically ill guy. I'm not adding a whole lot to the healthcare system other than, because I don't know what to say. So I am quite capable of using the technology to do a variety of things like that. But I remember going into the Revere Health Center at Massachusetts General Hospital, an underserved area, but waiting room packed. Elderly folks, English was not the #1 language in this room, and I suspect there was a reasonable amount of cognitive issues going through here. And I'm looking at this thing and say, this ain't Fitbit territory. This is a different set of problems, et cetera. So when we look at this consumer, and you say it's not like buying groceries or buying something out of Home Depot. It's consumer, but it's a really different kind of consumer experience. So when you all look at it, and I know a number of you all are spending time on how to engage consumers, recognize the phenomenal diversity of what it means to be a consumer and the different notion of what it is, quote, they are buying. So what do you think the role of technology is? And are we overdoing it? Sometimes we're overdoing it, looking for technical answers when that ain't the answer. This kind of stuff here.
Yeah, so I would agree with you. I think when we look at the populations that we're responsible for managing in our organization, so we have a Medicare Shared Savings Contract, we have a Medicaid ACO, and we also have a commercial ACO. And really, let's take a strategy such as disease management, which you were kind of alluding to. A strategy or a capability like disease management really varies across each of those lines in each of those populations. A disease management strategy in a 70-year-old plus population is probably an in-person, high-touch experience at a physical location. In a commercial population that's younger and perhaps more savvy, that's probably going to be some type of on-demand type of technology solution. In the Medicaid population, a disease management approach, which is really largely focused on children with asthma and pregnant mothers, is a high-touch, community-based intervention that is probably not clinical background individuals, but folks who have really great emotional intelligence, really great connection with the community. I just give that as an example because sometimes it's not a one-size-fits-all, and that is something we've really come to appreciate, especially when you look across one given capability. The second piece about, what's the role of technology and engagement, I have to be totally honest with you, at least on the delivery system side, I think we are very naive and just starting to understand this. We really haven't had to have that orientation around consumers, and we are just starting to understand notions of consumer segmentation, price sensitivity, the data that is required to understand and drive that. You know, the example I like to give about what does patient activation look like, what should it look like for us, you know? And the example I give is that video, that music video and song Gangnam Style, right? You know, like what does that have to do with anything, right? And no matter what whatever your taste is in music, you know, that is the most viewed YouTube video ever. And if you were to add up all the times that video has been viewed, that amounts to 14,000 years of human time. That's like greater than the amount of time that there's been civilization. People have watched this YouTube video, right? And you know, it's not even in English, right? It's in Korean, right? It's not even in the lingua franca of the globe, right? But the point is, imagine if we could take just 1,000th of that degree of activation and engagement that video generated, and if we could take just 1,000th of that or 1,000,000th of that type of activation and put it towards smoking cessation, high blood pressure control, weight management, that's what our industry needs to look like. It taps into disciplines that we just really don't have an understanding and we haven't brought to bear, such as viral marketing, behavioral economics, and that's where I think we need to go.
You know, being a HIT vendor association, I can speak probably less to what it needs to engage the community appropriately in the right settings. But what we can say, at least from a technology point of view, is that regardless of the right approach, the right use of patient-facing technologies and people that will make the right solutions happen, there are certain sort of basic necessities you just expect should be present in all those situations. And access to the core elements of the clinical chart actually maybe even in its entirety, are just things you'd expect to be ubiquitous. And from that point of view, you know, the ability to actually surface that information regardless of what the system is, regardless of what the technology is, so that it can be used as a small part, but an important part of whatever that actual solution is that really takes care of those patients in that community in the right setting. That should just be a sort of a constitutional right. It should just be fundamental to what we do.
I think there's simple things we can do. You know, can we adjust just the hours we will actually see a patient, so that maybe their son or daughter could bring them in to be seen? And you know, that's not very high tech, but it's very appropriate for trying to take care of the population the way you suggest, John. The other side is just technology. Holy cow. I mean, our ability now to take $100 Connect and put it in someone's home and monitor them and understand a lot about whether it's their gait or whether, you know, the other issues they might have in the home. And this is exploding, and it really does, you know, regardless of your cognitive ability, we can learn a lot and discern a lot through the new technologies that are out there. So it's really an exciting time to be involved with technology in healthcare. But we're going to have to cater to all the different needs, whether it's someone that's going to have an iPhone and have the Fitbit and the Apple Watch and 45 other things going up their arm, as opposed to, you know, grandma that my mother could never figure out how to use a PC. So I think we're going to have to cater to it all, and we're going to have a lot of strategies around consumerization.
So, I mean, I think patients and people as a passive recipient of care is not going to work. I think we're all agreeing activating patients is the way to go. You know, now whether that means having some Amazon drone drop the strep test right in your home, so you don't have to go and park and go to the hospital, and that's going to be a segment of the population. You know, Geisinger has done things, so we've been involved in the Open Notes project, which means that 220,000 patients have access to the notes that are written about them in the record, so that just goes out to them automatically. We have Bluetooth scales in the homes of patients in a different demographic with different sociology, you know, in terms of, you know, it could be a 75-year-old person with heart failure that we kind of stay on top of. So we put some tools in the home, moving some of the healthcare services out of the brick and mortar and out of the clinic and into the home so that we can still monitor what they're doing. But I think one of the things that's been articulated already is the idea that we have no clue what it is that a patient really wants. And sometimes when we listen to the patient, you know, we don't hear exactly what they really want, because the ideal way to communicate is not a rushed 5-minute visit, with the clinician. So to be able to, at our convenience, in our cottage industry, for them to arrive to us in the way that we want them according to our schedule, that's not going to be a person consumerism approach. So the whole sets of efforts in terms of what Netflix does, in terms of understanding what kind of movies you like, and then giving you those offers, or in terms of, the nice thing about this is that it's already out there in terms of how to approach the person. We just haven't adopted it completely yet, and we're just starting to learn in terms of as we activate patients and find out, oh, we thought this, but actually that's what's going on. I think we're going to learn a lot. This has to be a learning, iterative system with the patients.
I mean, two observations, and then we'll give it to our colleagues. One is talking to a colleague who said that when House of Cards came out, the Netflix thing, is how did they decide to do that? And they observed the behavior of people. What were they watching, and who were they watching? What were their favorite actors? And they put that into a combination that says, this kind of thriller about, government, this, that, and the other, and Kevin Spacey. And so they actually outlined a sketch of the serial based on the observed patterns. Very cool. It was remarkably well done. The other observation, and this was one of the student papers I got, and she did a nice job of looking at some of these technologies for someone who's as young as she is. And one of the observations was that when consumers are given technology to help them monitor conformance to whatever behavior you think they want them to do here, if you gave it to them and said, this is for you, to monitor you, that was vastly less effective than if the clinician said, this is for us, to work together on your health. So that social element, that human glue, that partnership was incredibly important in terms of the effectiveness of this kind of stuff to help lead to the right behavior change. Anyway, last question, then we'll open it up to our colleagues out in the audience here. So when you look at the range of IT investments, and I know your organizations are investing non-trivial amounts of money and effort on these things, and obviously we're in an IT, or health IT gathering and symposium here, and that's what we do for a living. But where do you think the most important investments are in terms of yield, in terms of all the things we're trying to get done? Boy, it's these two and these three that are really the critical levers for us. And Mark, we'll start with you.
Well, for yield, it would be in the area of patient engagement, how we actually get them brought into the care processes and link it in with the clinicians. It isn't where we're spending the most money. It just so happens to be on IS security right now. But it is, I think it is where we're going to get the greatest yield and the best benefit for society and the community we serve as all around patient.
Is there a number two?
Yeah, but there is, but I would go back to it being streamlining the processes for our clinicians, making it so much. I just think we waste a lot of their time, and they're a valued resource. We don't have enough. There isn't enough supply for the demand that's out there, and so I think we really need to pay a lot of attention to how we make their jobs not necessarily easier, but more streamlined so that they can do the things that they do best.
So we have a set of diabetic patients, and we came to an agreement across the organization of taking 9 things that we were going to measure on those diabetic patients, things that you would fail your boards if you didn't do reliably, that actually weren't being done reliably, even though everybody knew to do each one individually, just kind of in the process of care delivery, they weren't caught. So, and then when we did that, we tracked that for 3 years, we found that we were reducing the number of heart attacks, reducing the number of strokes, and retinopathy in this 30,000 patient group, and that was occurring while still bending the cost curve. So while the overall cost of the care and the quality was going up. So from my perspective, I think investing in understanding what really is the reality at the front, at the front line, kind of the creative tension that exists between actually understanding what reality is and then being able to pull the innovation on top of that to kind of re-engineer healthcare. I think using the IT tools as a lever to re-engineer what's actually going on and being able to bundle things around care processes is where I'm going to get the most yield, because I'm going to be able to prove that actually what I'm doing is having a positive impact, as opposed to imagine that I buy a health IT tool, put it in, and then magically it will make things better. Because it's a lot about provider behavior, it's a lot about patient activation, and I think you need to understand how those things come together.
So going back to your original question, which was, what are sort of the 2 or 3 key HIT investments that probably give the biggest bang for the buck. I totally agree with Mark on the first one. You know, consumer-facing, consumer-engaging software and applications and technology. I think that is absolutely critical for us in a population health environment. The second critical investment that I believe in, that we are actually pursuing as well, is really applications and software that sits on top of the layer of all of the data. I don't need another EMR, I gotta be honest with you, okay? What I need to do is actually have something that takes all my data in from all of my 6 different EMRs that we have across our multi-hospital, multi-clinic, independent physician system, right? That takes in external data from our payers and applications that sit on top of that that actually allow me to leverage, utilize, and see that information in a way that I haven't before. So I think that's our second really critical for us as an organization, HIT investment.
You know, I don't claim to have the expertise as to what is the most valuable, next IT investment that a provider organization, or even necessarily a vendor, should make. I can say I know what the least valuable investment is, and that is the next CCDA interface, the next BDT interface. Those are the things which, and the sad part is today, I'm sure it's true for large provider organizations, but it's definitely true for vendor organizations, that substantial sums of resources, of people, are dedicated to building these one-off interfaces, these single interfaces that A, it's not scalable, and B, does not create the type of value that you can create when you know that all your EMRs in your hospital system are connected, and that you can build actual useful applications that are value added on top of it. And if I think about that as an investment, the primary issue there is we become used to it. Whether it's a cost center for you or a revenue center for you, we're used to having large investments in interfaces which actually provide minimal value relative to the kind of value you can build if those are a commodity. And that's what we're trying to do.
So just one other thing is kind of piggybacking on what you said. With Apple and the iPhone, it wasn't the hardware or the technology that made it extraordinary. It was harnessing the collective power of all the people that were developing the apps on top of it. So the data layer that you're talking about, that takes all these transactional systems and then gives a platform for people to build their innovative technologies and so forth, to be able to create different views and so forth. I mean, that's what we're just starting to do now. So it's not that the Epics and the Cerners and the things need to go away. They're essential components of the framework. But it's going to be that we need to have mechanisms, and Smart and Fire and what we're doing with our energy, rheumatology app and the other families of apps that we're starting to market through our external XG Health Solutions group. That's going to be a market that that will be able to make available that value back to all of us, independent of whatever transactional systems we have.
Yeah, I mean, I think the sort of opening of the sort of core transaction-oriented systems, and one way to do it is through Smart Fire Standards and others, just make the interoperability, the movement of data back and forth between those systems, offers extraordinary opportunity here. I mean, it's just an interesting set of, if you look at the amount of venture capital money invested in HIT in 2010, it was approximately $1 billion and approximately 100 deals. If you look at 2014, it was about $6.5 billion and approximately 500 deals. And so you say that pace, now that won't go on forever, that kind of trajectory. That being said, there's an extraordinary amount of innovation going on out there. And so the ability to leverage, these kinds of access to and capitalizing on smart people, whether they're clinicians in your all's organizations or young people out doing this, that, or the other, doesn't really matter. I think that what really opens up, it's not the only answer that we have, but it's a very important answer to a lot of innovation that will need to occur here. Why don't we turn over to my colleague Joanne and see who will guide whatever questions you all might have.
Okay, so we've got a question right out of the bat. We have microphones, so let me just wait for the microphone to come on up here. And we've got a question right up front. And then no.
Hi, Scott Bass from Health Leaders. One word I have not heard this morning is the cloud. And I'm curious to know, not talking about private hosting, I know Cerner's doing some private hosting, but what does the panel think of moving not just other technology, but even the EHR itself to the cloud, and there's been some interesting developments lately on that. I wonder what your thoughts are.
I think it's an exciting opportunity. I look at some of the things that are being done in the cloud. If you look at Salesforce.com and some of the things that they're doing and what it's offering to us as at least IT leaders to very quickly get to solutions to offer to our user base, it's pretty exciting. It also creates a de facto standard when it's in the cloud, so that you can do some pretty interesting things around innovation. So I'm very excited about it. I think 3 or 4 years ago, we looked at it and went, ooh, our compliance people were going, that's the cloud. You know, you're gonna take all our data and it's no longer in our control. But I really believe there's been tremendous advancement even in that space to where security and even getting our compliance people a little happier. We're in a better spot. So a lot of opportunity in the cloud. But Scott, I think there's a lot of variation in it as well. I mean, I do look at what we do with Cerner by running it out of Kansas City somewhat as a cloud. I got to treat that pretty similarly as a Salesforce.com or a Workday or something like that.
Jimmy, what about you? From a cloud perspective and Commonwealth, how does that play all in for your perspective?
So my personal view is that cloud-based interoperability is really the way to go. It's when you can when you are able to connect to the rest of the community through a platform that is centrally located, centrally hosted, and is able to connect everywhere, then you've achieved the scale. At the end of the day, what we really want is for interoperability to be like a utility in the sense that it's ubiquitous and low cost. And cloud gives you that scalability. We are lucky in that being a relatively new organization, just 2 years old, we can start there, and so we have been from the beginning. To Mark's point, when you have started elsewhere, then there's a lot of shift in mentality that has to come before you can actually get to that.
You know, I think almost all of our predictive models and analytics we are running on a population health basis and inpatient basis are running off the cloud. And what I love is that as the data scientist and statistician team comes up with improvements to those models, little tweaks, a little something that gives it just a little bit more predictive ability, a little bit more statistical accuracy, those changes can be made very easily, no disruption to the user at all, and actually an improvement in care. And I love that, right? So we actually have all these small incremental changes that are occurring, and then if you look over some period of time, you're like, wow, I have a model that's 20% better than what it was when I first deployed, and I did this in this small iterative way. And it's not disruptive to the user. We don't have this big downtime associated with it, or a pause or a retraining that's required. So I think that's great from a impacting clinical care perspective.
Next.
Okay, this is for Joanne and John. When you're out there, I have to bring this up. When you're at, this is Sean Sutter from Search Health IT. When you're out there fighting, when your salespeople are out there fighting out with in the trenches with Epic, is interoperability kind of your calling card? Is the open architecture, the possibility, the stuff these guys are talking about, is that what you're selling, offering the customers? And John, is that one of the things why reasons the Siemens sites are staying with Cerner?
I mean, I can start. I think there's multiple calling cards, so to speak. Interoperability obviously happens to be one, and it's because of the criticality of what these folks point out. They need to bring together multiple elements of the delivery system for population health purposes, for direct treatment purposes, et cetera. But it also involves, reaching out to consumers and their devices. It also involves, as we mentioned at the tail end of this conversation, opening up to fire standards and others to enable this ecosystem to flourish. But it's not the only calling card. I mean, there are other calling cards that range from, to what degree is the product line and the products diverse and deep. And so you really understand whether it's revenue cycle or the emergency department or the ICU, et cetera. You understand how that function works, and to one of Mark's and others' points is make sure the clinician's job is focused and they're not wasting a lot of time, et cetera. It also involves, where are you? What are you doing in the population health analytics realm? Because increasingly that is important, and so there's a variety of work that we go on with folks like that. It also involves to what degree are you taking sort of knowledge of the evidence and the best way to treat and embedding it in the product. Hence, a lot of the work we do with Intermountain Healthcare becomes quite critical. So it is a multifaceted proposition here, and these are very large investments that people are making and very large commitments of organizational resources to go off and get all this stuff to occur with a lot at stake. And so what you are working with when you form a relationship with us or with anybody out in this realm is not a one-trick pony, or one-axis specialization. You got to make sure there's depth and skill and breadth on multiple fronts. And that's sort of that's the conversation, which is why these are complicated conversations, because there's multiple areas in which you talk about strengths and capabilities, et cetera.
I would add to it, a lot of what we do is really go in and understand what's the problems the organization is trying to solve, because that really articulates then what do you talk to them about and bring to the table. What I find more and more is organizations are looking for a longer-term partner versus a IT vendor of a transaction system. So literally they are trying to figure out, hey, healthcare in the future is pretty uneven. We're not really sure. It's hard to predict what's going to be happening. I mean, we think we have a roadmap. Who is going to be with me and actually guide me and help me and be that lever for the future versus who's just going to get my EMR in place? Because I think that more and more people are finding that paying that much money for just an EMR and a transaction system isn't really going to get them what they need in the long term. So I think that's where then you think about interoperability, you think about partnership, you think about vision, you think about the different aspects of the world as it's going in the future and what our organization is looking for. So it's not like a one-trick pony, hey, it's interop and that's the buzzword. I mean, if you walk around the HIMSS floor, certainly it is the buzzword today. But people recognize that it's not just about the transaction system. I've got to know that I've got to be able to do more than that. And that is a lot of what Alistair was talking about on the Smart and Fire and the apps that can fit within that workflow. So there are pieces of that, but it's not just that. Other questions? We've got another one right.
Hi, I'm Fred Pizzoli from Health Data Management. On Friday, there was some rollback on the patient engagement criteria by CMS. Some of that was met with a lot of industry angst about how we're undoing all that we've done. Just want to get your feelings on whether that's a good development for the industry, a setback, any feelings you might have on that. I just want to throw that open to the panel.
So I don't think we rolled anything back. Clearly we were on a path to engage patients to make sure that they get their data. Yeah, they definitely relaxed that requirement, and anything that makes it more likely that health systems and hospitals and providers can achieve meaningful use is going to be a positive part to that program. And I think ultimately the market's going to determine whether or not you're doing that well, whether or not you're sharing the data, and because people are going to want that. And so, I just don't see it as that massive of a, let's get a lot of angst around the relaxation of that one particular requirement of meaningful use, because I think it's going to bring more people to the table and have this program have at least a better shot at being successful for this program.
I think having a little bit of headroom for some innovation, I think is a good approach. At Geisinger, just like I'm sure with my colleagues here, our roadmap is not based on the meaningful use criteria.
We were just always aiming for 25%.
Right, exactly.
That's where we were going.
Exactly. So, I mean, we all have patient engagement strategies, and those don't vanish because the criteria changes. So I think that, but allowing to have a little bit more flexibility to be able to do things which aren't immediately within the constraints of a numerator and denominator, I think is going to be helpful.
And I can ask one while we're waiting. So we talked a lot about the consumer and are they ready to engage in the way we really think they need. What about how we're training our clinicians of the future? Are we training them to think about things in the future? And then how does that actually impact how academic medical centers start positioning themselves and, for different care delivery models? I mean, that was based upon the old, very inpatient-centric model. Any thoughts? And I'll throw it to Alistair first.
So I have two comments about that. Mark Bornstein from Georgia Tech has a group of about 250 students that are preparing for masters and PhDs and various things. And they're engineers, so they're introduced to the healthcare environment and the health IT market for the first time. And their first reaction is fairly visceral, because they're young kids and they're tweeting and using all the Trellos and everything else in terms of it, and they're kind of going, this is how you guys do it? It doesn't make any sense. So there's that aspect of, the people who are writing things now innovatively and so forth are trying to understand why are things set up the way they're set up. The second thing I'll say is that in medical school, we teach, we don't say to a medical student, okay, here's a blank EMR, and we're going to talk about heart failure. And so we're going to talk about where you find the ultrasound, where you find the ejection fraction of heart failure, where's the note, how has the patient got a number of other medical conditions associated with heart failure in medical school. Go find out, all this information, learn how to address the alerts, and they're going to pop up as you try to apply medications and now they are an ACE inhibitor and so forth. And then learn about heart failure using kind of this framework of an EHR to learn. And then go on to the next thing. Instead, it is still traditional books and notes and and descriptions of signs and symptoms and treatment recommendations with absolutely no correlation whatsoever to what happens on day one of the internship, where the intern has a beeper from the 1980s and and has to go take care of the patient in a completely brand new way that they haven't been prepared for 4 years on the medical education. Doesn't make any sense.
I'm encouraged though. I think there are some areas of progression and reform that are occurring in medical education. I think students and honestly their teachers are realizing that you can't master all knowledge. And that's a really big shift from how we were actually trained, which was that in the first 2 years, let's try to teach you all the science that's possible. And now a recognition that that's really just not possible. But what's more important is that you actually can look and access the science in a very facile and quick way when you need to. So that makes me be a little more encouraged. The other part, when I sort of interact with newer house staff, is that they're being exposed to people that we weren't exposed to in our training, like care managers and navigators and social workers and pharmacy actually doing clinical work. And I think that's actually adjusting what they see of as their role and not necessarily always being, the lead in care. So I think it's occurring slowly and in these sort of subtle ways that's got me a little encouraged actually. The truth is that I think that generation understands things, or gosh, I can't believe I just said that I'm not that new generation. But that generation has a different understanding that is, I think, going to help us. But it is going to take time. And unfortunately, I think there's a generation of physicians that are actively saying, you know what, this private practice model and what is required for me, I can't cut this, and maybe it's time for me to retire.
Comment on that, Joanne, and I'd be curious to particularly you two gentlemen's reaction to this. I spent Thursday, Friday, and Saturday with a gathering of 20 people that was sponsored by the Macy Foundation, which you may be aware spends philanthropic money on advancing health professions education, largely medical school, nursing school, but other allied health professions. Anyway, and so the room's full of deans of nursing school and deans of medical schools, et cetera, trying to talk about not only the future of that education, but particularly the role of IT in that education, which is the reason that I was part of that discussion. And there's a set part that says about the student in school now, the medical student, the nursing student, and all that stuff. Perhaps the biggest educational need is the working clinician, who is talking about the amazing transformation. How do you intercept someone who's 35, 45, or 55 and teach them while they're delivering care, et cetera? And one of the thoughts was, and this may come back to us as suppliers to this industry, is you could use decision support, which is intercepting a decision or lack thereof, and saying not only do we want to get you back on course, so to speak, but this is a teachable moment. And so you deliver a chunk, whatever the chunk is, 5 minutes of education, 15 minutes of education, et cetera. The other is using the analytics, and so that as you look at practice patterns, say we got a bunch of folks here who are not quite with the program here, is to target the education based on where there's a perceived deficiency. So there's a personalization of an education plan, which is largely a reflection, or often a reflection of the observed practice. You know, you did this, but you didn't do that, or is that so? So it may become an augmentation of the electronic health records. And what I don't know is your true, reaction to that kind of idea is that you reach the working clinician's educational needs in the context of the use of the systems and the analytics.
Yeah, I think we absolutely have to, and I think that the notion, and you were kind of alluding to it a little bit earlier, John, when you were talking about how things were framed to patients in terms of is it for you or is it in partnership with you, how do you nudge, I'm going to use that word very intentionally, how do you nudge the working clinician actually into a different pattern of practice and behavior? And that is absolutely essential. And I think they kind of know and recognize that as well, that they need to be nudged and to change how they're practicing at times. I think technology plays an important role. I think particularly for this group who's actively working, it's also a human interaction and a peer effect that is also extremely important to drive and nudge that change.
One thing that I think the transactional systems are doing pretty well actually is providing some of that information. So, I can get a list of every single physician, for example, and I can sort that list by the ones that write the most number of notes in the most efficient way versus the ones that are really taking their time and hovering all over the place and trying to find things. And so I can take what is otherwise a blunt instrument of training before a go live and worry less about that and turn that more into 10 to 15 second quick video snippets and screensaver shots that are kind of constantly flipping on all their computers months ahead of a go live as a way to kind of market out this information, but really do much more tailored focus training based on their behavior against the system, and identify who the super users are and then who the ones that need a lot more assistance. So I think those tools that exist, a little bit across the board now are very useful. And the same thing, is a concept of where there is a care gap that's been identified because you know that this is what you're supposed to do but you didn't do it. Obviously, we've learned that the interruptive alerts are not really helping us out. But what we can do is run those care gaps on a regular basis and put it back in a workflow in a sort of a more passive way to make sure that when there's time to address them, that they're being addressed in a way that's easy. So I think those two pieces are going to help continuous process improvement.
And I think that this is going to continue to change over time. And I don't think this is something we have to look at it in med school. If we've been going live with Cerner just very recently, we have learned a lot about how we should configure the system. Intermountain's had a lot of success using data to change behavior. Generally, it's been around clinical processes and clinical care, and we've been very organized around that. What we're learning through this implementation process is if we have that same level of data that Alistair was just talking about, we're able to change behavior. We're able to teach better about, exactly, you've been hovering over here too long, or this order, if you actually just went over here, you could order in 1 click versus 14 over here. And that is changing adoption. That's changing just attitude around the system. So I think we have a lot of powerful tools built into these systems now that's really helping to make it more successful and bring these clinicians quicker up to speed.
I can't resist asking Mark, Alistair, and Rishi.
Here's the microphone. Oh, sorry.
I can't resist asking Mark, Alistair, and Rishi what your plans are to embrace Commonwealth, since we have the Commonwealth folks
I thought you were going to ask what our plans are for tonight.
No.
Where's the party?
Anyway, I'm just curious to know, how quickly do you think you'll actually onboard the Commonwealth services in your own systems?
I personally don't know how quick we would onboard. I can say very convincingly, though, that the value proposition that is represented is absolutely core to our success in population health. We have I think, fairly decent understanding now, thanks largely to our partnership with Cerner in terms of understanding what's going on within our organization. But for our attributed patients, somewhere about 40% of their spend is occurring outside of our organization. And our line of sight into that in a meaningful way, particularly from a clinical standpoint, is extremely, extremely limited to almost none. So our embracing of it is absolutely core and critical to us being able to succeed in population health.
So my answer is going to be a little bit different in the sense that, we're aware of the fact that actually, from a federal perspective, the whole issue around patient ID has been embargoed ever since 1999. So that it's not been, it was in the HIPAA regulation, it was mandated in the HIPAA regulation, never funded, and continues to be embargoed every single year by our Congress going forward. And everybody who's tried to kind of debunk that with petitions and so forth can't function. So the fact that it's going Commonwealth to have industry help solve that problem, I think, is the only next best thing that we can do if we do not have a supportive government who's convinced that using algorithmic matching is the only way that we can get things done. That being said, your transactional system needs to be part of the party. My transaction system is not. Even though, as a client, I would like it to be.
I'm sure there's people here that would love to change that.
I think it's similar. I mean, several of our vendors are members of Commonwealth, therefore I think we are using it. And so we are, bought into Commonwealth. We'll have to look at to what degree we're going to embrace. But I thought right afterwards we could have a big hug.
We have last question here from Dave.
Yeah, and this came from Twitter. Actually, it's a follow-up to Mark Probst mentioned earlier that standards are a national emergency to get in place, and the question comes from Twitter: who bears the responsibility for not implementing data standards?
Well, I think we all would bear the responsibility for not implementing standards. Which one of the 3,000 would people like us to implement? And I think that's the leadership we're really looking for, is to define the set of standards that we should all go implement. And there's a lot of reasons why there's so many standards out there. And almost every one of those reasons has good intent behind it. But the fact of the matter is, we don't have a good common set of standards to do our work to implement, to allow for good data interchange. And if we as a government would just simply say, you drive down the right side of the road, everybody drives down the right side of the road. If you don't drive down the right side of the road, there's penalties for not doing it, and they're fairly severe. Then we will all start riding down the right side of the road. Then we can work on dash lines and different shapes of signs. But we need to get to that common set of standards. And I just really think, I think it was brought up earlier, we've had about 40 years to get this done. It hasn't happened. Something more dramatic, something more direct needs to happen for us to get this in place. And people are dying every year because we're not dealing with this problem. And I have no other opinion.
That's a good point.
Well, with that, I think we'll bring this to a close. Thank you all for coming early. We appreciate it. Really enjoyed it. We also thank you to panelists for coming and sharing your wisdom. If you would like to have some follow-up questions or one-on-one, we can arrange that. Either you can see one of the Cerner people that we've got around here to help arrange that, or we can figure something out here during the conference. So thank you all.